Hi, good evening, everyone, and thank you for joining us for our Woo You event with Dr. Melissa Barnett. Her presentation is titled Fact versus Fiction, Tackling Common Contact Lens Myths. So I'll be your host tonight. My name is Dr. Ariel Sorenzi. So I would like to introduce our speaker. Dr. Melissa Barnett is probably a stranger to none of you guys. She speaks internationally and is an expert in lots of things, but especially contact lenses. And we are in for a treat today to get to hear from one of the world expert on contact lenses. So I'm going to go ahead and let you take it away, Dr. Barnett.
Great. Well, thank you so much for the kind introductions. Here you can see some disclosures. All financial relationships have been mitigated. And so awesome to see so many of you on this lecture tonight and to talk about contact lenses, which is one of my favorite things. If you have any questions, please feel free to send me an email, as you can see here. So this is kind of a fun lecture. Tonight, we're going to talk about common contact lens myths, fact versus fiction. And it's sort of a fun format, but hopefully, as always, you can gain a few pearls. You can take it back to practice tomorrow. You can talk to your patients about some new options. And also in this lecture, you're going to learn some random fun facts about contact lenses. Please feel free to follow me. It's so fun to talk, to continue the conversation on social, on LinkedIn, Instagram. You can listen to our Globalized podcast if you're interested in practitioners from around the world. It's really fun with Tom Arnold there. And I'm very fortunate to work with many companies to grow our wonderful profession. I think it's the best of eye care. Okay, so we're going to start with the first fact or fiction. Contact lens wearers must wear lenses full time. And I would love it if you type in the chat just to make this a little bit interactive and say, is this true or false? Okay, so let's just have some fun. Is this true that all contact lens wearers must wear their lenses all the time? Oh, thank you so much. So many of you are responding. That's awesome. So let's talk about the global contact lens market. It is huge and it is growing. So it's valued at almost $8 billion in 2020, and it continues to grow from $8.58 billion in 2021 to $12.56 billion in 2028. So that's a compound annual growth rate of 5.6 in that forecast period. And just think of all the things that contact lenses can offer us. In North America, growing as well, 7.45% from 2021 to 2026. And we know that contact lenses provide so many benefits and that usage tends to drop off even in age mid-30s or so, and especially over age 40. So this is also when ametropia increases. We have lots of patients who come in, say they're presbyopic, they have some sort of refractive error, they've never worn contact lenses. Contact lenses are an option for them. And we know that half of contact lens wearers actually drop out after age 45, but contact lenses provide so many benefits that we need to share with our patients. Here you can see just another graphic. 93% of presbyopes were not wearing multifocal lenses at the time of dropout. We're going to talk about that later in this lecture today. But you can see all these patients drop out of contact lenses. And I will say, and here we're talking about normal cornea contact lenses, or say we're talking about soft lenses, we have the best contact lens technology now compared to even 10 years ago, 15, 20 years ago. The technology is so much better, and we still have a lot of people dropping out of contact lenses. So I know we all know this, but let's just review the benefits of contact lenses. What about freedom? The ability to do anything. Right now in Northern California, a lot of people are going skiing. I'm actually going skiing too. And contact lenses offer that great peripheral vision. Contact lenses help with that youthful appearance, right? Compared to glasses. And being glasses free allows us to do so many things, right? We can do so many things. We can look at all sorts of directions. It really helps improve our peripheral vision. and the benefits of, say, part-time wear. And I always like to ask my patients this. I ask them, how often do you like to wear contact lenses? I ask it just like that. And I want to know, do they wear them? Do they want to wear them all the time? Sometimes? If it's sometimes, for what? Is it social? Is it for sports? Is it both? Is it on some days of the week versus others? Is it when it's raining? Is it to change the eye color? These are all questions that I ask. And for those who are new to contact lenses, I tell them, I understand, it might be a hard answer because if you've never worn contact lenses, it's really difficult to know how often you want to wear them. But it really is helpful. And this can be for someone who's 20 years old or someone who's 60 years old. I like to ask how often they like to wear contact lenses. And hopefully you'll gather that from this fact versus fiction, that patients do not need to wear contact lenses all day, every day. It is absolutely fine to wear them occasionally. Now, contact lenses also really benefit the practice. So over-the-counter self-prescribing is not done as much. It differentiates your practice. I'm constantly amazed when patients are referred to me for, say, a soft multifocal contact lens fitting, because all of you can do that very, very well. Follow that fitting guide. It's important to make our patients happy. And then they refer their friends and family, which increases your revenue. And of course, don't forget about the other revenue that this can bring to your practice, because patients don't just get glasses and contact lenses, of course. They need your medical expertise to address the dry eye, to address their glaucoma, cataracts, whatever it might be. So it can really help grow your practice by incorporating contact lenses. And of course, we know about mask-associated dry eye. I'm still struggling with this in clinic here in California. We're still masking and everything's fogging still. Patients understand that. So with contact lenses, very beneficial, especially when face masks are worn, because the hot air that goes into the eye and dries out the eye and fogs up glasses and all that, contact lenses are quite helpful there. So we all know these strategies: taping the top of the mask, making sure that the mask is well fit, limiting time with direct air and air conditioning, using topical eye drops over, taking breaks on digital devices, hydration, 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 really important. So thank you all. Gosh, 89 of you for responding in the chat. That's so awesome. And now we know that contact lenses can be worn part-time, and they can be prescribed really for anyone who's interested in contact lens wear. Okay, so moving on to the next fact or fiction. Daily replacement contact lenses are wasteful. Okay, again, I'm gonna have you type in the chat. Do you think daily replacement contact lenses are wasteful? Yes or no? And let's talk about it. I love this part. We know that plastic is everywhere. So 32, and this is just plastic in general. 32% of plastic packaging ends up in the ocean each year, and 91% of plastic has never been recycled. That statistic shocked me here in California, because I have patients asking all the time about if contact lenses can be recycled, and we have recycling programs. We recycle a lot. We talk about recycling a lot here. Now, this was from about a year ago from Contact Lens Spectrum, and I just want to give you sort of an idea of daily replacement contact lenses. So a year ago, it was about 43% of patients fit in daily replacement contact lenses, and here you can see the different types of contact lenses fit. And then this was from Contact Lens Spectrum, January of 2023, so just last month. And this is looking across the world, daily disposables as a proportion of soft lens fits, 2018 to 2022. And I put the little arrow so you could see, just highlighting different countries there. In the US, you could see it's a little bit lower. So it's about 3 over more than 40%, but still we have a lot of opportunity to increase our daily replacement contact lens prescribing. Now, 15 to 20, this is like a fun fact that you can take back to clinic tomorrow. 15 to 20% of contact lens wearers flush contact lenses down the sink or toilet. What? That's crazy. That's absolutely nuts. And an annual supply of daily replacement contact lenses produces 11.36 grams of dehydrated plastic waste, but compared to just one 20-ounce water bottle that has the equivalent weight of 1,586 dehydrated contact lenses, which is a 2.17-year supply. So when your patients come in and say, well, I don't want to be fit with daily replacement contact lenses, it's such a waste. One, you can inform them, educate them not to flush them down the sink or the toilet. But you can also use this fun fact, comparing a water bottle and saying, well, actually, it's not that wasteful because compared to just one water bottle, you can have more than an annual supply of contact lenses. Now, we know that reusable lenses that are worn for more than one day, require solution bottles and cases. Of course, we need disinfection. And a single bottle, I like to talk about this too, a single bottle of multi-purpose contact lens solution, the weight of that is equivalent to 2.5 years of daily replacement contact lenses. And then a peroxide case is equal to more than 8 years of contact lenses. So just the plastic alone. And not to the recycling point, but to the cost point, when you're talking, I'm a huge fan of daily replacement contact lenses, if you didn't gather that. But the reason why I love them so much, one, clean and healthy lens every single day. Number two, it's so convenient for patients having a lens that can be disposed of or recycled every day, not flushed down the sink or the toilet, it's so convenient. So we have healthy options, we have convenient options, but then I do like to bring in the cost of solution when we're talking about the cost of daily replacement contact lenses, because if patients are compliant and they're actually cleaning lenses appropriately, that solution cost is really going to add up. But good news is that the contact lens case, solution, and cleaner bottles can all be recycled in that number 5 recycling, which has a high melting point. So there are different opportunities for recycling, and I'm just going to share a few of them with you. But you can see different companies have different recycling programs. And what we have in clinic, we actually have a large box where we recycle our contact lenses. And then we have smaller boxes that we give to patients so they can recycle their own contact lenses. And for example, my son here at home, he wears soft contact lenses, and we have little boxes where he recycles his contact lenses. So this is a program by Bausch & Lomb. You can see the 1x1 and BioTrue eye care recycling program that has recycled millions of units of used contact lenses, eye care, and lens materials. I wanted to throw a picture of elephants maybe next time, but it's the equivalent to the weight of approximately 31 elephants. Fun fact. Cooper Vision has the first of its kind plastic neutrality initiative, and this is expanded to include additional countries in Europe and Latin America, and launching soon in Asia as well. Alcon has recycling and has actually been recognized for their recycling programs. And Johnson & Johnson also has recycling as well. And all AccuView brand contact lenses are made with 100% renewable electricity. So here you can see a short video about the recycling. So now you know that you can go back, inform your patients about the benefits of recycling contact lenses. And of course, this can be done for everything. So the contact lenses, the bottles, the solution cases, etc. Okay, next, fact or fiction. Time to type in the chat again. Multifocal contact lenses don't work. And the reason why I started with this is a doctor in practice who is under 10 years of practice told me flat out, multifocal contact lenses don't work. And I looked and I said, what? What are you talking about? So let's talk about multifocal contact lenses. So we all know about presbyopia, and I do want to just share a few fun facts about presbyopia. It affects 128 million American presbyopes, almost 2 billion are affected globally, and almost 31 million people buy over-the-counter readers. Have you ever been in a store and you see someone trying to select their readers? It's pretty comical. But this is important. Patients are really frustrated by reading glasses. And I always like to eliminate reading glasses over contact lenses. So if a patient needs to wear, say, reading glasses occasionally in certain circumstances, or very, very occasionally for certain, if they're in a dark room or very small, tiny things, or they need to wear them just now and again, that's okay. But patients are frustrated by the reading glasses. Here you can see the frustration. Wearing reading glasses makes me feel old. I feel frustrated when I forget to bring my reading glasses to a business meeting or restaurant. Wearing reading glasses makes me feel less attractive. And we know that presbyopes, there's so many presbyopes now. We have presbyopes who are in their 40s, and very famous ones are in their 40s. Presbyopes are not all 80, and contact lenses provide so many different benefits. This is one that I do want to share, that the loss of near vision was reported as the number 1 or 2 most impactful condition. So 60%, this is where 1,000 people were surveyed about age-related conditions, which really surprised me if you look at dry eye, which is only 14%. So the loss of near vision is really impactful. I'm sure that many of you have had patients that wake up in the morning and suddenly they have presbyopia. They call your office urgently and they come right in because they suddenly cannot see up close, right? But presbyopia, it's frustrating. It impacts patients' lives. And fortunately, we do have a lot of great options for our presbyopes. So sharing just the latest classification, you can download this all free of charge, and you can see that presbyopia is now mild, moderate, and advanced. You can see the near vision correction, especially in contact lenses and multifocal contact lenses. We don't want to have too much plus. We don't want to push the plus too much for up close, because we have really great designs when it comes to multifocal lenses. And here you can see the different categories for each. I would encourage you to be checking the near vision. So really important, however you want to check it, whether it's with a reading card, whether it's with a phone, but having some sort of documentation of how the contact lens helps the patient is really helpful. So of course, when it comes to contact lenses, we have many different options. We have multifocal lenses, we have modified monovision, we have distance contact lenses, reading glasses over, and then just straight monovision. Sometimes people ask me, well, what does modified monovision mean? So you could have a soft toric, say, in one eye. You could have a near, and then a multifocal in another. You could have a distance. You could have sort of a mid-range. So there are all sorts of options that we can do. But what do the studies say? The studies really show the benefits of multifocal contact lenses. And that the studies, time and time again, the benefits are in real world situations. So not in the exam room, in people's lives, which is really the most important. So when I have patients in my room and they have multifocals for the first time, I do like to talk about that adaptation, that it might take a good 2 weeks for them to get used to the multifocal lenses. Most get used to them much quicker than that. But some, very, very few, it does take a little bit longer for that brain adaptation to get used to them. So here you can see on the bottom right, Jill Woods, the objective findings in the exam room. Monovision were the best performer for high and low contrast near vision tests, but in the real world, the monovision were the lowest performers and multifocals are the highest performers for things like night driving, television, and computer use. And in many different types of studies with different types of contact lenses, multifocal contact lenses still are preferred by the majority of patients. Now, looking at these numbers, and this is a little bit older, but the numbers haven't changed a whole lot. So only 8% of presbyopes have been told about multifocals. 1 in 3 presbyopes want to try multifocal lenses. And what I do in my practice is I talk to patients, and now we have all sorts of options, right, for presbyopia. So we have pharmaceutical options, of course, we have glasses, there's surgical options, there are contact lens options. If I have a new patient who I don't have that really established rapport with, I like to just talk to them about all the options. If I have a patient that I've talked to before, I know what they're going to like. I still tell them about all the options. We have contact lenses, and they might say, well, I don't know if I want contact lenses. I might want that next year. Great, I document it. We talked about multifocal contact lenses. Consider for the next time. It doesn't even have to be a year. It could be at the next exam. Sometimes they'll come back. Oh, yes, I do want to try those contact lenses. Same thing for, say, a pharmaceutical option for presbyopia. Have that discussion, document it. It's really helpful for continuing that discussion. 1 in 3 patients would switch doctors if not told about multifocals. I hope that's not true, but this is what this article said. And the majority of contact lens wearers want to stay in contact lenses as they age. We know that's for sure as well. Now, we know the issues with monovision. So many people are not successful. The depth perception is off, night driving, halos and glare, that limited intermediate, the lack of binocular vision, and it's pretty difficult to switch to multifocal contact lenses when in monovision, especially for those patients who are more advanced with presbyopia. So why start early with multifocals? Well, it's a whole lot easier to deal with a low ad than a high ad. It's much easier to fit patients at this time. And I would say it's fine to fit patients when they're less than 40 years old. That's absolutely fine to fit patients in multifocal lenses, because what are we all doing so much? We're on digital devices. We're on computers, we're on screens. Ask your patients how many digital devices they're using. It's typically more than 3. And ask how many hours a day they're using them. I'm laughing a little bit. I had a patient this week who came in urgently for an urgent visit for a new onset of double vision diplopia. And he told me truly that he is on a screen or a digital device every single moment that he's awake. And the only time he's not is when he's sleeping. And so he had horrible convergence insufficiency. And we talked about all the things, breaks and et cetera, et cetera. But, taking breaks on computers and digital devices is very important. But we don't want to be lazy and lead to monovision. So we don't want to be pushing a little plus and that non-dominant eye, a little more, and then suddenly we're in full-blown monovision. So it's really important to identify these patients, talk about studies. I like to talk about studies with my patients that multifocals really outperform monovision. We want to start early, and it's important to go over the fitting process, fees, training, etc. This is a great article on optics of multifocals. This is from the CLEAR report. This one specifically was chaired by Catherine Richdale and talks about all the different types of multifocal lenses that are available. And it's just great. So a little plug for the CLEAR report here. The contact lens report, every single section is fantastic. I'd encourage you to read it if you haven't already. There are summaries of it if you don't want to read the whole thing. There's a podcast of the whole CLEAR report as well if you just want a taste of it. But it's an excellent report if you're interested in contact lenses, all things contact lenses. And we don't want our patients to drop out of contact lenses. So this is from TFOS in 2013, going over what we can change. Of course, we can change contact lens factors. We can change the material design, fit and wear, and lens care. And then, of course, we can change the environmental factors and that external environment. but we don't want patients to drop out of contact lenses. So here you can see at the bottom, patients are kind of struggling with contact lens wear, and then eventually they discontinue and completely drop out of contact lens wear. Now, what about astigmatism? So astigmatism is really important when we're fitting contact lenses, and 0.75 is that flinch level. So we do want to know, is it corneal astigmatism? So measuring corneal curvature in whatever way you'd like to do that. Or is it lenticular astigmatism? Is astigmatism in the dominant eye or non-dominant eye? And when corneal astigmatism does not equal spectacle astigmatism, we have all sorts of different options, including soft toric multifocal lenses that actually work, I would say now, compared to many years ago when they didn't work well, I think, monovision. And of course, I like to avoid the reading glasses if possible there. Of course, we can get fancy. And I like to tell my patients, yes, we can always get fancy. So we can start basic, we can get fancy, we could completely go to fancy right away. But we do have lots and lots of options in contact lenses and in multifocal lenses. So we have corneal GPs, of course. We have hybrid lenses with great multifocal designs. We have scleral lenses. You can see the image on the upper left there of a scleral lens that has little hash marks, so you can see the centration. Many different scleral companies can decenter optics on multifocal lenses to provide our patients really crisp and clear vision. And it's just so much fun, I think, to fit multifocal scleral lenses. So getting back to sort of multifocal fitting steps in general, we do want an accurate refraction. So I like to get my own refraction, and I tell my technicians this, even if the patient has been seen in our clinic, even if they were seen yesterday, I'm still going to do a really quick refraction. And this is for all patients, just to make sure that I'm using my numbers so that I can get the best results here. We don't want any more minus than necessary, especially for multifocal lenses. Even plus a quarter can make a really big difference. So I really like to fine tune the refraction. And we don't want too much of an add because so much of our lives now are with that mid-range or intermediate vision. And so we don't want to over push it there. Now, what about dominant? So I would encourage you all to be checking dominant eye. Maybe tomorrow, check it in your first 10 patients. I don't care if they're presbyopes or not. And it's important to be checking dominant eye using the sensory dominance. So that's the sensitivity to blur. So you just take a trial lens, you put a 150 or 2 over each eye, and there are a few ways to do this. If a patient's if they come in with their habitual prescription, they have good vision in each eye, quick, check dominant eye. If they're in the phoropter, you could even put the ret lens, very quick. And you want to ask which is more blurry. And that is going to be the dominant eye. And the sensory dominance is really, really helpful when fitting multifocal lenses. Now we know sighting dominance is creating a triangle looking through one eye, and the eye that holds the position is the dominant eye, but this is not as accurate. There are studies that look at sensory compared to sighting dominance, and they're not actually always the same as well. So that's something else to keep in mind. But tomorrow, your first 10 patients, sensory dominance. Let me know how it goes. Okay, then we want to talk about lens modality. So offering our patients different lenses, going over everything, just like we do with any contact lens. Choosing initial lenses by following the fitting guide. And I won't make you chant this, but I do have students chant this to follow the fitting guide. And students do so well with multifocal fitting because they follow the fitting guide. So each company has fitting guides. You can put the fitting guide on the fit set. Many of these fit guides are available online or in an app, so very easy to access. Following the fitting guide, very important. Put the lenses on, let them settle a little bit. This is the only time I do have my patients pull out their phone because it is good to look at the phone. Usually I don't like my patients to have their phone at all. And I like to talk to my patients about adaptation and that it's important to let the lenses settle. Like any other contact lens, we want to evaluate the movement, coverage, centration, comfort, Everything's the same. How's the vision? How's the comfort? And now we want to check binocularly. So with both eyes open, distance and near, if they're using a mid-range task, checking that too. Oftentimes it's a computer. Starting with larger letters, say 2040, we don't want to start with 2020 and say, can you see that tiny, tiny letter? And I love when my patients bring in whatever they might bring in. So I had a patient the other day bring in a music stand and music, and I thought, this is fantastic. You're actually bringing the music that you need to look at. And it was so easy to fit the contact lenses, and they could see it right there in the room, in the exam room with the music stand, that they could see clearly at the music distance, which is fantastic. Now, what about if vision is blurry and patients come in, oh no, it's not as clear as I want it to be. So ask, where is it blurry? Is it blurry far away, up close, mid-range? Please describe the blur. Is it shadowy or glary or contrast or blurry? What exactly is it? And we always want to consider adaptation, but going back, we want to make sure that we do have an accurate refraction. Again, you can double check it really, really quick. Make sure that you didn't over minus, even by minus a quarter. We want to make sure that the correct lenses are on each eye. That's always important to do. We want to make sure that the lenses are settled and centered. And initially, of course, we always want to set realistic expectations. Unfortunately, multifocal contact lenses are not going to make you 20 years old. They're not going to take away your wrinkles. I'm sorry if you see more of your wrinkles if you're wearing multifocal lenses, but we want to set realistic expectations with multifocal contact lenses. Now, we always want to do a binocular over refraction using loose lenses or trial lenses. So having a patient sit there, putting lenses over. I love those flippers that have plus and minus a quarter and a half. I find them really easy. We do have them in every room to quickly check an over refraction. And then sometimes I'll even take my patient outside of the exam room and have them look at different distances. Very often I'll have them go look way outside the window to make sure it's actually clear, demonstrating that over refraction, especially if it's just a tiny bit of an over refraction, to make sure they like it. And of course, if it's a plus over refraction, they're probably going to like it up close as well. Important to make a single change at a time. We don't want to increase the ad. We don't want it to be too much. And we don't want to be making so many changes. So at this point, it should be very small changes, maybe in one eye, maybe in both eyes, to help improve vision. So when we're checking, again, just very subtle changes here. I really don't like to, if I'm even at like minus a half, I think I probably did something wrong. Maybe I need to go back and double check the refraction, because it's typically just a plus a quarter, maybe even a minus a quarter, very, very small changes. So adaptation, reassure the patient. This might take some time. This is completely normal. In the exam room, when they're looking at something up close, oh yeah, it's kind of that blurry overlapping double. Oh, completely normal. Give them homework. I always like to tell my patients, go do your normal things that you do and come back and tell me. And I do document initially what they want to do with these contact lenses. Is it for bike riding? Is it to specifically watch a show? Is it for work? What is it? And are the expectations met when they come back? How's the bike riding going? How is your computer use going? Whatever it might be. And lighting is so important. I feel like we talk about this all the time, but it is really important in educating our patients. So if you're in a dim restaurant and it might be a little bit challenging to see the menu, the good news is we all have phones with lights on them. So just turn on the light on your phone for that one specific instance. If you're at work, if you're on a digital device, talking about lighting, also really helpful. And the importance of follow-up. Depending on what lens you're using, some sort of follow-up is great. If you want to see the patient back and double check everything, that's fantastic. If it's a really tiny change And say it's a power change in an existing multifocal lens wearer, I oftentimes just have them send me a message and I finalize the prescription for them. So when they're coming back, we want to ask our patients how they're doing, performing the overrefraction, looking at the lenses, taking the lenses off the eyes, looking at the eyes, of course, addressing ocular surface disease and dry eye. But I think that this slide here is one of the most important. This is the troubleshooting. So the troubleshooting fit guides are not always completely intuitive. Sometimes it seems a little strange and weird. However, these fit guides are based off of thousands of patients, not our hundreds of patients that we might have in our practice. So have these advanced or troubleshooting fit guides handy. If a patient is saying, well, I can't see well at distance, I can't see well up close, whatever it might be, go ahead and take a look at the fit guide and then use that, even if it doesn't seem like it makes sense, but oftentimes they do work and help solve the problem that the patient is having. So don't make too many changes, use real world situations, and just know when to stop. I mean, there are times when you just need to stop and have that conversation with the patient. And I don't like doing this, but sometimes you have to and say, okay, you're 20/20 at distance, you're 20/20 up close, and you're telling me that things are blurry. What can we do? And oftentimes it's just having that conversation. And then the patient will say, oh, actually, I can do everything I want to do. I just thought I could see as well as when I was 10 years old. Okay, this is good that we had this conversation, and that's not maybe the case. And then suddenly they're happy. So it is really important to manage discomfort and dryness, especially with multifocal lens wearers, especially those who are presbyopes. Talking about solutions are very important. If it's a reusable lens, we know that hydrogen peroxide solutions are a great option. They are also effective against COVID, against coronavirus. This is a study looking at multi-purpose versus hydrogen peroxide, and hydrogen peroxide and povidone iodine solutions were helpful against coronavirus. Again, fun facts that you can take back to clinic. And we know the benefits of daily disposable lenses, but for multifocals, it's great because clean, healthy lens, we already established that patients don't have to wear contact lenses every single day, and they don't have these gross, disgusting cases because they replace and throw away lenses. We know that the risk of adverse events is lower with the daily replacement lenses, and we have many excellent options for daily replacement multifocals. So I would really strongly encourage you to fit daily replacement multifocals to offer these lenses for all of your patients who are interested in contact lens wear and who are presbyopes. Now, here are some guidelines for in-office disinfection. So say you're fitting scleral lenses or corneal lenses or other types of lenses that are worn on more than one patient and fit on more than one patient. These can be downloaded free of charge, and you have all the information here. Okay, that was a fun one. So now we're moving. You knew that scleral lenses had to be in this lecture somewhere. I always like to tie them in, of course. Okay, time to get out the chat again. So this one, fact or fiction, scleral lenses are only used for irregular eyes. Okay, let's see those numbers come. So we know that scleral lenses can be used for our patients who have severe dry eye and severe ocular surface disease. And the rationale here is that scleral lenses are beautiful to hydrate that ocular surface. They protect the ocular surface, and they can be used in the most extreme cases that we see for ocular surface disease and irregular astigmatism, of course. But scleral lenses can promote corneal healing. They can improve comfort, improve the quality of life of our patients, and really help the surface of the eyes. So again, going for the more severe ocular surface disease, scleral lenses can be successfully fit. and those who have, say, persistent epithelial defects. For those who have autoimmune disease like Sjogren's, they can be used for neurotrophic keratitis, graft versus host, Stephen Johnson. But what about for our normal eyes or our regular astigmatism? Well, good news is that scleral lenses can be used for all patients. So they can be used for those who wear soft contact lenses, who are uncomfortable, those who have high refractive errors, athletes. Scleral lenses are a great option there. Presbyopia, I love it when a patient comes in and they might have some sort of refractive error like myopia, hyperopia, astigmatism, presbyopia. They might have a little bit of dry eye there as well. A scleral lens is a great option. And even for people who have, say, giant papillary conjunctivitis or significant allergies, scleral lenses are a great option there as well. So when we're fitting normal eyes, it's just like fitting irregular corneas. And there are many different scleral lens designs now that are used for those who have normal, regular astigmatism, normal shaped eyes. And we're learning so much about eye shape, which is so fun too. And scleral lenses are a great option. So just like when we're fitting for severe ocular surface disease, scleral lenses for normal eyes, we have preservative-free solutions in the bowl of the lens. We do want to optimize our materials. Oftentimes we can go a little bit smaller in diameter. We do need to disinfect lenses at night. And of course, we want the scleral lens to land evenly on that scleral conjunctiva. So this is a fun project that a few of us are talking about now, but if you look back to the TFOS-DES2 Management and Therapy Report, where scleral lenses are listed here, they're listed as step 3. Okay, so this is after any sort of prescription medication prior to surgical procedures like punctal occlusion, amniotic membrane grafts. And our argument is really that scleral lenses should be more in the step 2 than the step 3 when we're talking about dry eye disease in general. So I'd love to, get out the chat and tell me what you think about that. But I think that scleral lenses can be fit very successfully. There are many studies. We did one at UC Davis. There are many others that have been done on scleral lenses for normal eyes. And there are studies looking at scleral lenses compared to soft toric lenses, and that people really do appreciate the benefits of scleral lenses. So this was a study that we did, myself, Chandra Mickles, Jen Harthen. This is looking at scleral lens wearers with dry eye, and this is looking at a polyethylene glycol PEG-based surface treatment with surface-treated and untreated lenses. And the surface-treated lenses for those who had dry eye provided improved comfort, reduced dry eye, and reduced ocular surface compromise. So we know that this surface treatment really helps improve wettability, reduces deposits, increases lubricity, reduces fogging, and can be used not just on scleral lenses, of course, but on corneal lenses, on hybrid lenses, and on soft lenses as well. So just kind of going through scleral lenses for normal eyes, just the same as those who have irregular eyes. Now that we have scleroprofilometry, it's a great tool in our practice, even for those with normal eyes, to really align the lens on that scleral conjunctiva beautifully, and we can select lenses based on that. We can also fit lenses very successfully diagnostically. And we know that scleral lens fitting is based on sagittal height, which does not correspond with keratometry readings. So the numbers are not going to be exactly the same of the scleral lens compared to the glasses prescription. My patients ask me that all the time. And of course, we want our lenses to beautifully align on that scleral conjunctiva. Okay, so I think that fact versus fiction was answered there. Okay, next one is contact lenses should always be fit on the same day as the eye exam. Get out your responses in the chat. Let me know what you think about that. And I realize it does it's based on your practice a bit here too. But The importance here is to really evaluate the ocular surface. It's important to evaluate the ocular surface in all patients, but especially when we're fitting contact lenses. So we want to look at the eyelids and lashes. We want to look for any sort of meibomian gland dysfunction, blepharitis, Demodex, lid wiper. Important to flip the lids, look for incomplete eyelid seal. We do want to address and evaluate the cornea as well. So the point here is that when I'm looking at my patients now, when I go into the room, I'm actually looking at them and looking at them across the room because I can get so much out of that view. So it's that global view before diving into the slit lamp. And what am I looking for? I'm looking for things like eyelid position. Do they have ptosis? Looking at their hands. Do they have rheumatoid arthritis? Looking at their body. Do they have diabetes? Looking at all of these things, I think, is really important before getting that really high magnified view. Okay, getting back to that dry eye. So we want to look for tear film stability, tear volume. We want to evaluate the ocular surface. I really like to use lissamine green stain as well as fluorescein. And I do like to have my patients close their eyes to look for incomplete eyelid seal and also Demodex as well. So meibomian gland dysfunction, very, very important, especially in our patients who wear contact lenses. And once you start looking for those abnormal blood vessels or telangiectasia on the eyelids, we see that so many of our patients have ocular rosacea. It's very, very common, and it can influence contact lens wear. So we know that contact lenses divide the tear film into the pre and post lens tear film. And so it thins the tear film. With a soft contact lens, there's more evaporation of that tear film. And I actually explain this to my patients, and they really understand that. I say a contact lens just separates the tear film into the pre and post lens tear film. Oh, okay. And so that's why I want to optimize the surface of your eyes and go over all the different things that we can do. So when we're managing the ocular surface, it's important to educate our patients that this is a complex disease. So the fact versus fiction is, do we fit our patients the same day in contact lenses? I would say it depends. So if they're coming in, if they have irregular astigmatism, if they have some sort of condition where you're using and fitting a medical contact lens, yes, it would be fine to fit the contact lens and manage the ocular surface disease at the same time. So for example, a patient comes in, I fit them with a scleral lens, I get them started on all the treatments for the ocular surface, order the lenses, have them come back, and then dispense and train, etc. However, I would argue that if you have a patient who is coming in for, say, a soft contact lens, who it's not medically necessary, it would be ideal to manage that ocular surface, especially if you're fitting, say, a soft multifocal contact lens, because you're going to get the best numbers and the best outcomes. So say you're fitting a soft multifocal and the eyes are really dry. Well, I'm going to want to address the ocular surface, have the patient back, double check the refraction very quickly to make sure it's actually accurate, and then fit the contact lens. So that's going to benefit us where we have a really good starting point to fit the contact lens versus we're fitting this irregular, very dry surface where the tears are breaking up incredibly rapidly, which then blurs the vision, so patients aren't successful. And we don't want to be switching contact lenses, this brand and that brand and solutions and this and that. We really want a great starting point to fit our patients with our contact lenses. So important to tell our patients, educate them that there's homework that they need to do at home, that dry eye is a chronic condition, that the treatment can last a long time. Now, sometimes we play around with it. Sometimes I reduce, and maybe oftentimes I do, reduce the treatment over time, especially now that we have in-office procedures, so there's not as much home therapy. But we do want to educate our patients that you're not going to just use this for a week and then suddenly never need it again. And we know that dry eye really affects quality of life. and that there is a light at the end of the tunnel, and we have many great options there. So there are so many things that we can do to address the ocular surface. I threw this slide in here to stress the importance of recommending or prescribing a artificial tear. So now we have some great options, such as preservative-free multi-dose options for artificial tears. We want to make sure we avoid preservatives. We always want to be checking corneal sensitivity, looking for neurotrophic keratitis. There are all sorts of oral medications, but here are a few studies showing that they are not really benefiting patients. And I am a fan of omegas, especially specific omegas that have, say, GLA in there. And because this lecture is so fun, I'm going to show you another fun video here. So I hope not too many of you are eating dinner right now. Here in California, it's kind of dinner time. But we know that Demodex is really common and can be present in really everyone. Very interesting looking at studies. Demodex is present in those who are young, patients who are young, those who are older, in about 69% of all blepharitis cases, and is very prevalent in those who wear contact lenses as well. So I would encourage you and all your patients, have them close their eyes or look down to evaluate for Demodex. And having collarettes is really indicative of having Demodex blepharitis. So great news is that there is an emerging treatment soon to come, which is TP-03, that, as you can see in that fun video where it's just killing those Demodex mites, that it's safe and effective. It's a topical eye drop treatment that can be used for all patients and hopefully really help our patients who wear contact lenses to keep our patients in contact lenses to prevent contact lens dropout. So really exciting times when it comes to meibomian gland dysfunction, blepharitis as well. Also, just ending here because I know that we have some questions, but going over makeup and products, very, very important, especially in those who wear contact lenses. So I want to optimize the ocular surface. I want to make sure that my patients are not using anything that's harmful. So the EWG website is one that I really like to have patients look at the products that they're using. And products can include everything. It can include sunscreen, lotions. We're not just talking makeup here, but that's a really helpful website. And then if you want, there are some really great products that you can recommend for your patients. So going over specific products to help optimize the ocular surface, prevent the meibomian gland dysfunction, and really be able to keep our patients in contact lenses. So with that, I'm going to answer any questions. I want to thank you all for your great attention and participation.